So David, let's just start.
Yep.
I sent you that research and that I read that is specific to breast cancer rehab and PEC minor issues. And because I read your research, I could fully understand it more. So what I want to do is for you to, people can go and read your research, and we invite them to, because what we want to do is look at the impairment of PEC minor. So with your research, David, how did you actually get into this study?
So I had an interest in the influence of soft tissues around the shoulder girdle and how tightness in any of those tissues could change the way that the scapula moves on the thorax. But what really got me interested in the PEC minor was one of my PhD students as a physical therapist. He worked exclusively with survivors of breast cancer. And so this was a new patient population for me. And through the reading the research that he and I did, we discovered that underlying shoulder problems in breast cancer survivors was not well recognized. And it's interesting because it is a huge factor in terms of mortality. And so we started digging further into that. And the more that I understood the different medical treatments that were given to that patient population, and the more he and I started looking at muscles around the shoulder girdle, pectoralis minor kept coming up as this is likely a muscle that's going to be affected with the various treatments that these women undergo. And could tightness in this muscle play a big role in shoulder dysfunction and limited arm use? And so that's really where it all started from.
And David, that's interesting because that research was published in 2011, so obviously you started earlier than that. And do you know that to this day, research is still focusing on the problems that people can experience, the upper extremity problems, but they're still calling for what is the impairment. So you've been looking at impairments for a long time.
Yeah, we have, and we wanted to find a good way to measure the pectoralis minor length and determine if it was actually tight. And so, there are a number of different ways that have been reported in the literature to do that. The big problem that we saw with those is the measurements are taken with the individual either standing up and their arms relaxed at their side, or they're done when they're in a supine position. And they never adds the next step, which is to lengthen that tissue to see if it is indeed tight. And so the analogy that we started talking to ourselves about and telling others is, you don't assess somebody's hamstring length when they're standing upright. You flex the hip to 90 degrees, extend the knee. So why are we looking at assessing the length of pectoralis minor differently? And that's what really helped to inform the method that we're currently using. The challenge that we saw with this is, how do you try to isolate the pectoralis minor from other muscles like the pectoralis major? And it was really work that was done by Meraki, and he published in the Physical Therapy Journal in 2009, where he did a cadaveric study to look at best ways to lengthen the pectoralis minor. And so it's from that study that we developed our clinical procedures. And based upon the work that they did, and then there was another article in JOSPT in 2011 by Stegen and Jansen, where they did a computer model of how to lengthen the pectoralis major muscle. And they found that with the arm up at 90 degrees and externally rotated to 90 degrees was a good way to do that. So putting those two studies together, we really think that the procedure that we've come up with is good for isolating the pectoralis minor as much as you possibly can in vivo. and not having your measurements confounded by any other major muscles.
And David, just to be really boringly basic, but when you are measuring the muscle at its length, then what if it comes up? Let's just say it comes up short. What should that describe?
Yeah, that's a really great question. So one of the things that, so we will take these, so ideally what this should tell us is this pectoralis minor muscle is tight and it needs to be stretched. What we are not 100% sure of is what is the cut point. So if you take your measurement and you do your calculations, you come up with a value. At what point do you say, all right, this is indicative of a tight muscle? There's just not enough data out there yet for us to come up with that value. So what I think is appropriate to do in the interim is to take a look at the other side. And if the other side has not been involved in any type of pathology or surgery, you could use that value and compare it to the affected side. And you could look to see if the side-to-side differences beats the measurement error. And if it does, and that's indicating that on the affected side you have a short pec minor muscle, then stretching would be indicated.
The resting length is when people are standing or sitting, and then when you put it on stretch, it's something that we don't really know about. Can you just explain that a little bit more?
Yeah, so this is something that the procedures take some practice for sure, because you're palpating the bottom part of the fourth rib, just a little bit lateral to the sternum. You're palpating the coracoid process and putting dots on those. And I think we've never run into a situation where we were unable to palpate those bony landmarks on any individual. And then, like you said, you're using your caliper to measure the distance between those two bony landmarks. And then when you go to lengthen the muscle, you're putting the glenohumeral joint in about 30 degrees of flexion. And then you're using the humerus as a fulcrum to push the shoulder in a posterior superior direction. So you're trying to push it up and back. And at the same time, you're stabilizing the thoracic spine. So you got one hand behind the person stabilizing the thoracic spine, one hand on the elbow controlling the amount of shoulder flexion. And then you're using the hand that's on the elbow to push the humerus in a superior posterior direction, lengthening the pectoralis minor. And it takes a lot of practice to feel that, but what best I can say is when you are doing it correctly, you feel like you're moving in a diagonal slot up and back. And then when that tissue has lengthened as much as it can go, you get a tissue firm end feel to it. But it definitely takes a lot of practice. And early on, the mistakes that people do is they end up pushing the shoulder into too much flexion or too much extension. And so it really takes a lot of handling and practice to get it. But once you feel it, then you're like, aha, that's what this feels like. And then obviously when you have that muscle in its length position, you need to have somebody else there to be able to replace the calipers so that they can measure that length and distance. So those things are drawbacks to the procedure, but I'm unaware of any other procedure that attempts to isolate the pectoralis minor muscle in a lengthened position and a resting position like this. And so I think it's well worth the time and effort to practice it. And I think it's well worth to have another set of hands in there to take that measurement so you can get what I think will be helpful information.
And David, you do mention in the research, one of your research papers about marking those bony points and then remarking those bony points because of things change.
Yeah, I think it's a good, when they're in that lengthened position, I do believe it is a good idea to recheck those landmarks to make sure they haven't shifted. And so the way that we would do that is we would ask the person to pull their shoulder blades up and then back and hold that position while we repalpated to see if we did need to remark. And off the top of my head, I don't remember the percentage of people that we have had to remark, but it's not all that much. And I can't say that one spot more than the other needs to remark. It's kind of variable all over the place. But I do believe that that's an important step to do to make sure that if in that individual there is a significant amount of soft tissue movement, you are capturing that and you're replacing your bony landmarks so that when that muscle is lengthened, you have accurate placements for your calipers.
Yes, that my mind boggles, and I'm really intrigued to look at that, because, for example, if someone's had a mastectomy, then they're going to have a lack of skin movement, and so which is going to be different to what you see in a normal population. So that in itself is an interesting question. The next thing that I would like to talk to you about is just the variance. And so in your, let's just say, your median measures for a group, it was something like the difference between a resting position and then a lengthened position was something like 4 centimeters.
Yeah, so if I had my papers right here in front of me, I could pull that up. One of the things that we did, so we used that length change to create a percentage elongation value, which I think is, it just puts that data in a slightly different perspective. But in our earlier studies, when we looked at the reliability, both within raters and between raters, we did determine what the measurement error of our procedure is. And what we can say is that the length changes that we have seen in the populations that we've studied do beat our measurement error, which is a good thing. And so that value is something that clinicians can use, that measurement error is something clinicians can use to let them know if they are making any changes in the length of that pectoralis minor muscle. Obviously, what you see in people who have a stiffer pectoralis minor muscle is that value difference gets smaller and smaller and smaller and smaller. And the first patient population where we really started to look at this was in manual wheelchair users. And we did show that the longer time that someone's in a manual wheelchair, the less flexible their pectoralis minor muscle is. So that was an encouraging piece of information because it makes sense. It's logical. It makes sense that if someone's in a wheelchair and using it for getting around and mobility, the longer they're in that wheelchair, because the position that they're in and pushing, you could speculate that their pectoralis minor muscle will be stiffer than in someone who's a newer user to the chair. But so I'm not sure if my doctoral student has plans to, what his plans are for the use of this measurement in breast cancer survivors. Since he has moved on into an academic position, I'm no longer working with that patient population, but my thought is that he will be. And when you reached out to me, I was extremely excited to hear that you were interested in talking about this and potentially using it for the women that you see and treat.
Yeah, you and I could talk for the whole day, but the other thing is that I want to just refer just briefly to the study on the effects of breast cancer surgery on chest tightness and upper limb function, and we'll have that in this series so that people can go look at it. But what they did was that they looked at like 3, 6, 9 months after surgery, and they didn't use the lengthened measure. They only used the two measures that you talked about in the earlier part, which was the resting length and then the supine bed to bone length, and so even in up to 9 months, and using only those 2 measures, that they got a change. But what I'm intrigued is that 9 months is not so long after surgery. Your the wheelchair users was like 5 years, 10 years. It was like 5-year increments.
I think that when that pectoralis minor muscle, assuming that it does shorten, which I believe that it can, I would see that unless somebody's doing something to address that and reverse that, they're going to stay in that shortened position. And then, the consequences of that, the one thing we found in the paper where we looked at the manual wheelchair users is those who had a shorter pectoralis minor muscle also had decreased glenohumeral elevation. So they couldn't flex their shoulders as far as those who had longer pectoralis minor muscles. So it's something that I think needs to be looked at, needs to be measured, and if tightness is found, an appropriate stretching program needs to be put in place to either prevent, maybe it's more of a preventative thing, prevent that from happening, or if it has shortened, then start to do appropriate treatments to restore the normal length of that muscle.
Yeah, thank you, David. Is there anything else that you would love to throw in that we haven't covered? Oh, yeah. I'm going to jump in, but you can think about.
Yeah.
One is that the basis for this is the model on alignment and impairment, the alignment and impairment model.
So the alignment impairment model is something that's been around for a while. It was something that originally was put forth by Shirley Sarman, and then John Borstead took that, and I think he was the one who coined this term alignment impairment model and published it. And it really is speaking about posture and alignment of different body regions, and that there is this, I don't want to say ideal, but typical. That in that typical alignment situation, we have optimal movement of the joints and optimal stresses going through the tissues. And that's the way that the body functions in a healthy, relatively pain-free manner. And the thought is that if you do something to create a malalignment, and so specific to the shoulder girdle, if you do something that pulls the shoulder girdle out of that typical or ideal aligned position on the thorax, it is then going to change the mechanics of the shoulder girdle, which will alter the stresses on the tissue, which could contribute to shoulder pain and dysfunction. And so thinking about the pectoralis minor muscle, it is absolutely something that if it's tight, could pull the shoulder out of its ideal alignment on the thorax and pull it forward and down. And now you have the shoulder girdle sitting in a position where when the person does go to move their hand in space, faulty mechanics are occurring at the shoulder, which results in abnormal stresses to the tissue and subsequent dysfunction.
Now, off research topic, David, and onto the treatment, just opinions. Do you have some favorite pec minor stretch exercises or activities, or on the reverse, the ones that just are high risk? Make it short.
Yeah, I think the most popular one, or the most familiar one for stretching is the corner stretch, where somebody goes like this, put their arms up into the corner of a room and leans forward, or they can call it the door. And I think that as long as there's no contraindication, so there's no instability at the glenohumeral joint, I think that's a fine stretch, because if the pectoralis minor truly is tight, I think you're going to engage the tightness of that tissue before you would engage the tightness in the pectoralis major muscle, which, this is the position that people use to stretch the pectoralis major muscle. So I think it's a reasonable one to try, because I don't have a great alternative for another way to do it. Now, one of the things that we thought about was when we ask individuals to elevate their shoulders and pinch their scapulas back to try to mimic the position that we put the shoulder girdle in when we push it passively, they are able to really lengthen that pectoralis minor muscle. Not as much as we can passively. So my thought would be that would be something that I would be working on educating them. But they got to have good form with that. So they need to see themselves when they do that in a mirror, that they're going up and back, because lots of times what I see people do and making a mistake is they'll go up, but when they go to pull their shoulder blades backwards, they also pull them down, right? So they're not ending up like this, but they're ending up like this. So I tell them, you have to like bury your neck, right? You got to go up and then go backwards, so it looks like you're just stuck your head and neck down into your chest. And if you can teach them how to do that, that does a nice job of lengthening the pectoralis minor muscle. We have seen that with our numbers. And so those two, I think, are reasonable ones to use.
You get people starting to talk about this, because the impairment of pec minor for me is secondary to radiotherapy, secondary to the lymph node, the axillary lymph node dissection, secondary to the surgical soft tissue and skin loss of movement. So, and it's really not addressed in this field. We address the lymph nodes, and the lymph nodes are taken, but people don't necessarily present with lymphedema straight away. Something happens over time. And I think that this is a good place to look at as the overtime event.
I agree. And, an earlier paper that we wrote was in the journal Medical Hypothesis, and it talked about factors that could lead to rotator cuff disease in breast cancer survivors. And we made the point that, a lot of attention has been given to lymphedema, which rightfully so it should be, but that's sort of cast a shadow over shoulder pain and dysfunction in this population. And it is a very, very significant problem. So I'm excited to hear that, you're excited about the potential use and value of this measurement. I am more than happy to help out in any way, shape, or form that I can in your endeavors with the use of this measurement. So please feel free to reach out, and like I said, I will help out in any way that I can.
Thanks, David.